Welcome to the Westport Library. Today's program will begin momentarily. Supported by Verso Studios, created locally and shared with the world.
Good evening, Westport. Oh, your applause. Thank you. You're all very good to give up such a beautiful night outdoors to be in here and talk about such an uplifting topic as cancer. Let's just say it out loud. I'm Andrew Wilk. I'm a very proud trustee of the Westport Library here, at least for the next 2 months, as I finish out my term. We're very excited to be back with our Westport Medical Series, which provides an opportunity for our community to learn about important medical issues of the day that affect all of us in one way or the other. Last year, if you were here, you knew that we discussed the types and various aspects of heart disease, including testing and diagnosis and treatment and prevention. Then we covered neurology, from strokes and TIAs to headaches. All of these interactive lectures were helmed by Dr. Robert Altbaum, who is again here with us tonight. We're lucky to have him. He is an esteemed Westport internist. Bob brought many of his friends and colleagues, medical specialists in their respective fields, to shed light on various conditions. So tonight we're beginning first in a 4-part series on cancer. Along with Dr. Altbaum, we're fortunate to have Dr. Richard Frank, an oncologist and hematologist from Norwalk Hospital. Dr. Altbaum will tell you more about Dr. Frank in just a bit. They will help us understand this disease better. That's a scary one, to say the least, and the newest developments in cancer care and potential cures that are allowing patients to live longer and healthier lives. On June 3rd, Dr. Altbaum will have some other doctor, physician, surgeon guests, and they'll dive into breast cancer. And the fall of 2025 will cover prostate and urological cancer, and our final presentation will explore the advances in lymphoma and leukemia. So now please help me welcome Dr. Robert Altbaum. Hey, Bob.
Well, thank you very much, Andrew, and welcome all to coming tonight. Really appreciate it. Tonight, my name is Bob Altbaum, as you know, and I am the medical director of the series under the auspices of Andrew Wilk. I really appreciate you coming out. Tonight, we have a very important topic to discuss. We're going to talk about our most feared disease, I suspect, which is cancer. I'm going to give you a general overview, and then my esteemed colleague and friend, Richard Frank, is going to give you a deep dive on some of the breakthroughs that have happened in cancer and why there's really optimism in the field of cancer. Currently, cancer is an incredibly common disease and a devastating one. 2 million Americans every year are diagnosed with the potentially life-threatening cancer. I'm not talking about basal cells or squamous cells of the skin. I'm talking about colon cancer, lung cancer, pancreatic cancer, cancers that can really kill you. And unfortunately, every year, 600,000 people do die of cancer. So what is cancer? Cancer is basically the uncontrolled multiplication or division of cells that continues unregulated. Normally it's regulated, it's unregulated. It creates a tumor, a growth, we call it a neoplasm, and this neoplasm is capable of invading tissue and of spreading through the bloodstream and through lymphatic channels. Now, I think we all know how it can possibly spread through the bloodstream. It invades the blood vessel and spreads wherever the blood goes. Most people don't realize that the lymph nodes in our neck or the lymph nodes in our groin that we sometimes feel if they get inflamed are part of a network. And this network is also another way that cancer can spread. Now, cancer, any cell in the body, any organ in the body can develop a cancer. And cancers in the different organs often have certain particular characteristics, and some of them have certain predilections to spread to certain organisms and certain organs. Rectal cancer goes to often the lung and the liver. Prostate cancer might go to the bone and the lymph nodes. They have different particular characteristics, and they're often, unfortunately, treated. Cancer isn't just one disease. It's really many diseases that are capable of spreading. When you look at the statistics of cancer, and I'm not going to beat you too much with statistics, but statistics show that if you take all genders, you can look at breast, prostate, lung. Those are the most common cancer types. And yet, what's the most common is not always what's the most deadly. And one of the reasons is we've made very good strides in doing screening and picking up certain cancers early. And we've also made strides in treatment. So when you look at the frequency of a cancer, maybe perhaps breast and prostate are the most common, but they're not necessarily the most common killers. Lung, colorectum, also they're in both genders. But interestingly, pancreatic cancer kind of typifies what I'm trying to say. It's the 10th most common cancer, and yet it's the 3rd most common killer. And this is breakdown on men and women, so this is gender specific. You can see how common prostate is in men and how common breast is in women. Good news, if you follow the orange line down, cancer mortality is improving in this country. Diagnosis isn't necessarily changing that much, but the cancer mortality is coming down. And that's largely due to improved diagnostics in terms of screening and improved treatments. So I do want to get back to what is cancer and just give you a little overview of cancer and how it develops. Cancer, again, is uncontrolled growth in the body. Now, we all have controlled growth. Every day, cells are multiplying. And basically, if you look at a fetus and becomes an adult, that's a lot of growth. That's a lot of multiplication. But it's regulated. It's controlled. Cancer loses that control. And that happens on the molecular level. And what we're going to do is I'm going to briefly talk about the molecular level, the cell cycle. It's biology 101, just so you can get a concept of why it's important that we have these magical treatments that are developing. And cancer starts, or ends, there we go. Cancer starts in the genes. Basically, you have a cell. Inside the cell is the nucleus, and in that nucleus are chromosomes that carry genes. Genes is made of the magical stuff of life called DNA. And DNA basically is a code. It's a code for proteins that control how cells move. It's a very complicated structure, but it really is quite remarkable in that it only has 4 chemicals, really, 4 nucleotides. And I like to think of them as letters. And those letters, when arranged in certain sequences, spell words, or in the case, proteins. So you have basically just those 4 letters, adenine, thymine, guanine, cytosine, and they, when arranged in a certain way, will become a protein. What happens in cancer is that that cell, that particular DNA structure can change, and it can change for many reasons. Again, here's the structure. What happens? Well, you have to duplicate DNA every time you make a new cell. So we have multiple chromosomes from each parent, 23 chromosomes from each parent, 23 pairs, and when the cell divides, it makes 23 new chromosomes. During that time, it's duplicating DNA. It has to make exactly the same copy of DNA. That's an incredibly complex thing for a gene to do. And it's a very vulnerable time where when the gene divides, it can make a mistake. It can lose one of those nucleotides, one of those letters. It can duplicate a letter. It can mistake a letter. So the word cat suddenly becomes the word tack. And that is a mutation. And that's basically what happens when we develop mutations. The importance of those mutations is if they happen in proteins and genes that regulate the cell, you can get cancer. Now, I'm going to liken a very simple analogy, which I hope kind of explains it. It's the analogy of a car. We have basically genes in our body that regulate growth, and they promote growth, and they're called proto-oncogenes. So these are genes that basically act like an accelerator. They're pushing the car forward. If you have a mutation during division, or maybe the mutation occurs because something damages the DNA, like sunlight or benzene, a chemical, or you have an inherited gene. When that happens, what happens is the accelerator can get stuck. The gene doesn't turn off. The protein keeps making the cell divide. Well, you basically accelerate the car, you crash into a cancer wall. That is one way that cancer develops. And those genes are called no longer proto-oncogenes, they're called oncogenes, or tumor genes. And it doesn't happen all at once. It can happen incrementally. You get a little change, a little change, a little change, and suddenly you have an oncogene. And it happens as it divides and as we age. So not surprisingly, cancer is more common as we age. The other gene that's very important is a gene called a tumor suppressor gene. And a tumor suppressor gene is a gene that normally controls or inhibits the growth. So you have a gene that promotes growth, you have a gene that inhibits growth, acts like a brake. Well, what happens if your brakes fail in a car? Car keeps going forward. So now you have two ways that things can go wrong. You can have a gene that mutates into an oncogene that doesn't turn off, or you can have a gene that stops working and becomes a malfunctioning brake, doesn't turn off, and you can have cancer. Again, just another analogy, doesn't have to happen all at once. It can have one mutation, two mutation, it can happen incrementally. And you may have heard of some of these genes. There are genes, like if you've known anyone with breast cancer, a HER2 gene would be an oncogene. There's a whole family of genes called RAS genes, or the RAS family, that are oncogenes. They promote growth and they don't turn off. Or there are genes that inhibit, and if they don't work, like the TP53, you can have, again, cancer that way. A third type of gene is a gene, remarkably, using this analogy, is the repairman. As genes keep multiplying and making mistakes, there's actually a method in the body to promote that to being repaired. It repairs the DNA and fixes the mutation. Well, what happens if the repairman's not there to fix the brakes or fix the accelerator? Again, things go wrong. And you may have heard of the BRCA gene. That's probably the most famous gene. That is a DNA repair gene. You get an inherited mutation from your family, you basically can get breast cancer or ovarian cancer or pancreatic cancer or prostate cancer. The gene is not repairing things. So a lot can happen in gene structure to promote cancer. And that's a very beyond simplified way. There's lots of things going on. There's immunology that basically fights off cancer. There is acetylation, methylation, chemical changes in the genes. But this is kind of a practical way to think of why genes and mutations create cancer. Now that's basically on the molecular level, the lower level. I want to get now on the bigger level, the level that we can control, which are risk factors. In a way, risk factors are things that promote DNA mutations. Now we already mentioned, or I already mentioned, age is one of them. As we get older, because genes are mutating and adds up. So age is a factor, we can't control it, but contributes to cancer. It's more common as we age. Also genetics, although genetics only make up a smaller percentage of actual cancer. Most cancers are acquired through mutations in life. But if you inherit a gene from a parent like the BRCA gene, your risk goes up because it can't repair the DNA. Now, even though we can't control those, they're important to know about because when we make guidelines for screening cancer, we can find that if we know there's an increased risk, we can check for things. If you have a BRCA gene, you can have MRIs regularly, or you might need a mastectomy or ovaries removed. If you are getting older, colorectal cancer goes up with age, but we know to check more and do colonoscopies, not at age 20, but at age 45. So we actually knowing these risks are very important. Smoking is probably the most common controllable cancer cause. It creates lots of carcinogens. And unfortunately, cancer contributes in some way to smoking contributes to up to 30% of cancers. That's an astonishing number to me. And it's at least influential in causing 13 different cancers, probably more. But it's just a powerful, powerful carcinogen. Now, unfortunately, the bad news, if you smoke, there is no good form of tobacco. Chewing tobacco, no tobacco is safe. The good news is if you stop smoking at any time in your life, as long as you haven't developed a fatal disease, you have improved your longevity. It's never too late. 60, 70, after 50 years of smoking, you still can make a difference. Obesity is linked to certain cancers. Not exactly sure how. It's through hormonal changes and through changes in the DNA, but basically it's linked to things like uterine cancer. And again, losing weight is something you can control. Diet. I think we all know that red meat is probably unhealthy. We think of it in terms of coronary disease, but it's also linked to cancer, as are overly processed foods and overly refined grains. So what could you do? Well, how do you do that? You could decrease your amount of red meat. You can eat less refined grains. You can move to a Mediterranean diet and eat colorful foods like fruits and vegetables. They're found to be safer in terms of cancer. Alcohol, unfortunately, was a few years ago bandied about as a good thing, at least in small amounts, because of coronary disease. And it seemed to be linked to a lower incidence of heart disease and heart attacks. That's becoming very questioned now, really is, unfortunately. But again, if you're going to make a difference in your life, at least don't drink to excess. At least for women, it's recommended they limit to 1 drink a day, and men 2 drinks a day because of metabolism differences. Less is more in terms of alcohol. It's linked to oral cancer, it's linked to GI cancer, it's linked to breast cancer. These are things, again, you can control. This is on the large level, but they really are affecting the DNA in the microscopic level. A few other things just to mention. Physical activity. If you could put physical activity in a pill, you couldn't afford it. It's just amazing what physical activity does. It's probably one of the few truly protective things in certain cancers. It's been found to be protective. In terms of HPV, which is a virus, I mention it not because it's just a virus that we have a vaccine for. It's a virus that's linked to oral cancer, it's linked to cervical cancer, and we have an effective vaccine that can lower that risk 80, 90%. Just a simple vaccine we give to children. An incredible cancer treatment, and it's really potentially almost a cure for certain cancers. Sun exposure, I think we all know about. It's not good for basal cells, not good for squamous cells, certainly not good for melanoma. We can use SPF 50. You can stay out of the sun, but again, something we can control. Chemical exposures, again, are basically occupational. I don't think it really applies to most of this audience. And genetics, always important to know. I just want to emphasize that knowing genetics in certain settings, you can't control it, but you can certainly screen for it. And that's the last one, my last slide really, other than a quick comment about the internet. Screening guidelines are very important. That's the other way you can control and prevent cancer, or at least keep yourself safe. Don't even look at, whoops, where'd this slide go? Don't even look at this slide in terms of reading it, because I have copies up here from the American Cancer Society. There's enough for the audience. But basically, guidelines are recommendations for screening patients based on risk. Most people are average risk, and they give you guidelines for both the average person and a person who's at higher risk. One thing I do want to comment strongly about guidelines, people misunderstand them. People have said to me many times, I don't need a colonoscopy, I have no risk, my family history is clean, I feel great. Those are the people that screening guidelines for. If you have a family history, you're at a different risk. If you have blood in your stool, you're no longer being screened, you're being diagnosed. So please understand, it's the healthy person that needs the screening, the one who doesn't think they have a problem. And the guidelines are based on your age, your risks, and they also try to think about things like cost and the risk-benefit of treatment and diagnosis. You don't know, overdiagnosing prostate cancer, which doesn't kill that many people considering the numbers. I mean, it still kills a lot of men. But certainly in terms of numbers, there are many who never die of prostate cancer. There's a constant argument in the literature how much we should do screening. Breast cancer mammograms gets argued about, but I think everybody's on the same page on that. And these are the guidelines from the American Cancer Society. Finally, the one last thing I want to leave before I introduce Dr. Frank is that anybody who gets cancer immediately wants to go to the internet. Absolutely understood. You should go to your doctor, you should go to Dr. Frank, but you immediately go to the internet. You want to take control of the situation. That's fine. The internet is an amazing repository of information. It's also an amazing repository of misinformation. And you can really go down a real rabbit hole. And I would just ask you, the simplest way to look at the internet for cancer research is to go to reputable sites. And reputable sites usually end in one of those 3 extensions: .edu means .education. It's an academic site. And academic sites have no axe to grind. They basically are educating you. That's what they do. They'll give you useful and accurate information. .gov, I hope it stays that way, but .gov in the past has been an accurate site, and again, no axe to grind. And finally, .org. .orgs are usually nonprofit organizations. They have nothing to sell. They're not trying to get you to buy anything. They basically are groups that are committed to educating and treating patients. Those three sites will get you excellent information on most, if all, cancers. The other ones that I would say are a little bit more sketchy are .coms, because they're commercial, that's what it stands for. They're selling you something. They're going to be biased. .biz, which is even lower than .coms in my opinion, are just businesses, again, trying to promote something. They are not unbiased. So stay with .gov, .org, and .edu. And if you are one of the people that like blogs, blogs are wonderful for personal support. They really seem to promote, I have a lot of patients who've gotten a lot of emotional support from blogs, but they are replete with misinformation and personal experiences that frequently have nothing to do with what you have. So I would say if you ever go to a blog and you ever feel like acting on it, please speak with your doctor first. Anyway, that's what I have to say. I'd like to now introduce my friend, my colleague, a great saxophonist, and the chief of clinical and translational cancer research at Nuvance Health, Dr. Richard Frank.
Every patient, hello. Thank you. Every patient I see from Westport says, "How could he have retired on me?" Bob. I can't get another doctor like that. That's true. He's exceptional. Anyway, thank you. So many friends are here, and I hope that we're going to do this in two parts. So the first one is kind of an overview of modern cancer therapies, and the second one is called Prognosis, Hope, and Uncertainty in Oncology. It really is dealing with more the life-threatening issues, the emotional aspects, making hard decisions. This is the easy part, the first part. So I'll just let me know if you need me to do something differently or what have you. All right. Okay. It's important to know, Bob was talking about conflicts of interest. No one's paying me anything. No companies. Bob kind of went through cancer by the numbers. We'll talk about new types of therapies and something about clinical trials. So I think we went through this already. I do want to point out that in terms of why, as Dr. Altbaum said, the mortality of cancer is dropping. If you look on the left is females, cancer death rates from 1930 through 2020, and on the right is males. The red curve that goes up and way down, that's lung cancer. And we'll talk about that. And the green one that's also headed down in both is colorectal cancer. And the orange one that is moving up in both, as Dr. Bob said, is pancreatic cancer. And there's prostate, others in there. But that's cancer mortality. Breast cancer in particular in women is the pink curve that also is headed down. Just to give you a quick statistic, the 5-year survival of breast cancer is 91%. The 5-year survival for pancreatic cancer is 13%. So there's a lot that has to be done. So we need foundations like the Billmeyer Foundation. Thank you. Blake Billmeyer is there. And he leads a golf outing every year that raises money for the Cancer Center. Next. This is what Dr. Altbaum was talking about. On the left is new cases in green. That's kind of about the same. And the survival is, death rate is dropping, so as more people are surviving. On the right is the number of survivors of cancer in the United States by decades. So you can see the first perpendicular line is 2022, where we are now. There's 18 million by the year 2030. There'll be 21.6 million by 2040, 26 million. So yes, people are getting cancer at the same rate, but they are living longer because we're doing a better job overall. Now, this is the main reason why, because we have better treatments, let's be honest. Because the cancers that couldn't be cured before are now getting cured, or people are living a lot longer. Early detection is absolutely critical, but only a third of people actually in the United States take advantage of mammography, colonoscopy, PSA screenings. The vast majority do not get screened. Certainly, if everyone, I know this is a very highly intelligent and audience that does get screened, and that's great, but the rest of the country has problems with it. But screening is one reason survivals are improving. And also I want to say that the care of the patient is improving. So if you have cancer and your white blood cell drops because you got chemotherapy, well, 50 years ago they didn't have things like Neupogen or Neulasta, or you may have heard these products that have been isolated, that are injected, that raise your white blood so you can immediately get out of trouble. So you don't, 40 years ago when people were getting chemotherapy and it knocked down their white blood cell count, they would sit in the hospital for weeks waiting for the bone marrow to recover to be healthy enough, and people would succumb just during that time. Or they wouldn't have antibiotics to treat it. Or people would get sick as hell from the chemotherapy and maybe not even take it. All of these supportive care aspects of cancer, of the care of the cancer patient, have dramatically improved. These are revolutions that have made the treatments better and helped survival, in addition to better pulmonary care and cardiac care and everything else. That when you do have cancer, a lot of things can go wrong in your body, not just every system can go wrong. But the number one reason why those curves are dropping is the new drugs. So this just shows you through the years, 2000 through 2023, is a steady rise in number of new drug approvals. The purple or blue is lung cancer, the green is breast cancer, the darker green is colon cancer, and so on. Obviously, you don't see pancreatic cancer there, you don't see brain tumors there. These are the more recalcitrant diseases. So when we talk about cancer treatments, well, surgery, we know, is there, and surgery has improved, but surgery will not cure a cancer that cannot be cured. And this is something also people sometimes put a lot of emphasis on, getting the right surgeon, but cancer in many cases is a systemic problem, and it's not, you don't have to find the greatest surgeon ever to do a certain routine cancer surgery, because it can be done perfectly well by a lot of doctors around you. It's not really the core of the issue. Radiation therapy, this is something that is advancing also rapidly with high-intensity therapies. Even in Norwalk Hospital, we give the most high-intensity therapy for pancreatic cancer, for example. Stereotactic radiosurgery for isolated brain metastases. So now, if someone has a cancer that's spread to their brain, they don't get the whole brain radiated, they get little pinpoint areas done. So you can remain mentally intact. It's very important. So there are advances in radiation. Chemotherapy is something that has a bad name, and for good reason, but there are chemotherapies that have cured cancers. The first one in particular was cisplatin that cured seminoma. And we still use the same chemotherapy that we used 40 years ago for testicular cancer, for example, because the cure rate is so high. None of these therapies I'm going to talk about have been introduced to the treatment of testicular cancer. We still use old-fashioned chemotherapy. So sometimes it's needed, it's often used, and more often in combination. But you're not going to see new chemotherapies because pharmaceutical companies have stopped mining the Amazons and wherever in nature where chemotherapies have been isolated from before. So very like Taxol from the the bark of the Pacific yew tree. There's other plants that have given chemotherapy drugs. That's sort of fallen by the wayside now. It doesn't happen. Everything is done molecularly targeted in a lab, in an AI facility. It's all very technical. Immunotherapy is the huge breakthrough of the last 15 years. Hormonal therapies, as you know, things like tamoxifen and Femara or anastrozole for breast cancer. For men, Leuprolide is a hormone therapy for prostate cancer. And I will say that prostate cancer treatments have not really gotten the attention that they should. Because there's just not a community to advocate, I don't think. And I think things like the hormonal therapies for prostate cancer, they cause impotence. And that is a huge issue for men. It's a little different than the hormonal therapies for breast cancer, for example. They're a little milder. They don't reduce or eliminate a person's sexual function. So those are very devastating therapies we really don't have enough research into. Targeted therapies, we're going to talk about those. Those are, like Dr. Bob said, directed to the DNA, and cellular therapies, we'll talk on those. All right, so as I said, from the 40s through the 2020s, what's happened with the new cancer products? There's a sign there, symbol for chemotherapy, the pill is the targeted therapy, and the DNA is the immunotherapy. You can see that chemotherapy, 70s, 80s, 90s, that was all major chemotherapy for breast cancer. As I said, testicular leukemias, childhood leukemias are curable still predominantly from chemotherapy. Lymphomas, those are highly receptive to chemotherapy. But then something happened in the 2010s, discoveries like for CML, leukemia called chronic myelogenous leukemia. A breakthrough was made in the discovery of the mutant gene. And this physician, Brian Drucker, this researcher at University of Washington, discovered that he was working out in the lab, and there's a great story about it. Of course, CML only affects about 5,000 Americans, so no drug company wanted to help him, but he managed to convince them, and they came up with Gleevec, which is now one of the biggest selling drugs in the world, because it doesn't just treat CML, it treats sarcomas, it treats a whole host of other cancers. You never know, once you make a finding, how it's going to reverberate through the world. And so he's amazing. It's an amazing story, but that was one of the first. The other was, as Bob said, Herceptin, which targets HER2. HER2 is discovered in a lab called Dennis Slayman, is a UCLA investigator. He discovered that that was very important to breast cancer, HER2 knew. Actually, he didn't discover HER2 knew. He discovered that it was important in breast cancer, but he was the one that pioneered trastuzumab or Herceptin. And these drugs are still being used today, even though they were discovered back in the 90s and early 2000s, and more so in the 2010s. What happened was targeted therapies, like for lung cancer. It was discovered that some people who are non-smokers have a different pathway to lung cancer than smokers. And this is even huger than it has ever been before. I know that's not a word, huger, but it's really big. So now when someone has lung cancer, the first thing is it's driven by smoking or it's non-smoking. Non-smoking, it's driven by a mutation in the DNA, usually only a few. And so when a person comes in with lung cancer, and we'll talk about it, they get a panel of genetic markers of the cancer, and that can lead to the discovery of a particular mutation, and the cancer is treated with a pill, like EGFR. We'll talk about it, drugs like osimertinib or Tarceva. These are oral therapies that have come around. They go inside the cell, they block a particular receptor. That's non-smoking related lung cancer, believe it or not. So 20% of lung cancers are in non-smokers. There's an incredible book called When Breath Becomes Air. I don't know if anybody read that. I recommend it. It's by this brilliant young neurosurgeon at Stanford who was a non-smoker, and he developed EGFR mutant lung cancer. He actually died, but he wrote about his whole journey, and he's a brilliant, would have been a brilliant writer, written many books, but he didn't make it. Nonetheless, many people do now live years with just a pill. So in the 2020s, we've evolved to immunotherapies, and we're going to talk about that. So all this talk about targeted, personalized medicine means that we have to understand what drives the cancer in each individual. And so, for example, let's say this is lung cancer. The light blue patients get their DNA sequenced of the cancer. This is not something you're born with. This is called tumor DNA or somatic mutation. This changes that just happened in the cancer. A normal cell became a cancer cell. How'd that happen? Well, now the genes that are involved in that are tested and are a routine part of everyday clinical practice in every oncologist's office. This is not something you need to go far and wide for. This is universal care. So let's say they have an EGFR mutation. They'll be treated with osimertinib. The purple ones have something called an ALK mutation, a different one. They get a different pill. This is how the third ones don't have any, but they may get chemotherapy or immunotherapy. Let's say that's the smoking-related lung cancer. So that is how we approach every advanced cancer, like this. Everyone with and even not advanced cancer, let's say just cancer that needs systemic therapies, pre-surgery even, post-surgery, or if surgery is not a part of it, it starts out too extensive in the body, the oncologist will get a complete profile of the cancer. Also, the hereditary aspect is another type of DNA that can be relevant at times, but mostly it's the DNA changes of the cancer. That's called genomic profiling. We'll give an example of it. That tells you what therapies you can use. So what are we talking about? Why do these targeted therapies work? As I just said, cancer cells, for example, may have what's called receptors on their surface. All cells have receptors. That's how they grow and they respond. The insulin receptor, the growth hormone receptor. These are thyroid receptor. So every molecule in our body acts on a cell by going into the cell or on the outside of the cell by binding to it, causing a reaction. And that tends to make the cell do what it's supposed to do. Now, if these receptors are excessive, or in the right-hand part, see the this thing becomes a solid. Those are called mutant receptors. It's different than the normal receptor. That's because of the DNA change in the cell led to that mutant receptor. And so all these situations are how modern drugs target the cancer cell. It can target a HER2 protein that's expressed way high on the cell, or it can express EGFR or another protein that's altered on the cell. And then we can go inside the cell. That's on the surface. Now let's go in the cell. Targeted therapies turn off growth signals inside the cancer cell. How do they do that? Well, basically, as we were saying, at the top there to the left, you see growth factor cytokine. That's a protein, a little protein that will signal that receptor and then send a cascade into the cell. Send it to grow. Send it to make insulin. Send it to make red blood. Send it to contract a muscle. Anything, any bodily function works a lot through this receptor system. In our brains, the way serotonin or other receptors, serotonin may work a little differently, but that's more neurochemicals. But anyway, in the body per se, which I know more than the brain, these receptors signal, but as Dr. Altbaum said, they stop, okay? We don't keep making insulin when we don't need it. We don't keep making the hormone that makes red blood if there's an equilibrium. The body's always in equilibrium. But in the cell over here, you can see to the right, that receptor is altered, or the cells the molecules that it interacts with are altered. So in this cascade, these signaling molecules, as Dr. Altbaum said, RAS, RAF, MEK, ERK, I know these look foreign to you, but these are proteins in almost every one of our cells. It's unbelievable. This is I-95 in Connecticut. I mean, and really, you know, so when a tanker wipes out, the road is open. after it. But anyway, so a mutation in any one of these steps in this domino effect cannot block the process, but make it go continuously. You no longer need that receptor to signal the cell. It's doing it on its own. So this is called small molecule targeted therapies. Again, when you do a DNA profile of a cancer cell, of a tumor, these mutations will be revealed, and then you'll know what drugs to use. So there have been a lot of drugs. This is just a small list, but we can start with all the way from Rituxan, which is a lymphoma drug in 1997 that was approved, revolutionized. There's imatinib in 2001, or Gleevec. So there are drugs for multiple myeloma here, bortezomib, temsirolimus, kidney cancer. You can see like vemurafenib in 2011, that targets the gene BRAF. If that BRAF protein is altered, then this targeted pill blocks it. So they all have, in the parentheses, the target. And that all came about through discoveries made in research labs, supported by the NIH, and the best labs in America. And there'd be none of this, absolutely none of it, without what the NIH has done and the NCI and the commitment that this country has made to the best and the brightest, the greatest people doing incredible work through great sacrifice often. It makes sense to just shut it all down. Okay. I don't know where the discoveries are going to come from if this persists. So this is, you're an oncologist and you're in your office and a patient comes in with stage 4 colon cancer, for example. Well, you would send that tumor, a biopsy of it, to one company. This one's called Foundation Medicine. There's others that they run a sample of like 500 genes of the cancer. It's taken from the biopsy. You don't need any other sampling. And they will tell you different things about it. And you'll see that under genomic findings, it says BRAF V600E. So if you recall the cell, yeah. So you see to the right, the RAS and then RAF, RAF, okay? We're talking about that protein is in this patient. It's mutated. So what would we use? Well, you don't need the company, but they sometimes do provide, if you look, see genomic findings, BRAF V600E, you go to the right, it says therapies with clinical relevance, encorafenib and cetuximab. So those are medications that through clinical trials have been shown to work for this particular mutation. And it also tells you that there are other medications that cannot be used because of the presence of this mutation. All right, now this field has exploded. This is just drugs approved in the US for different mutations in lung cancer. All I can say is we've talked about this gene EGFR at the top right. That was the first targeted therapy. Now there are, I don't know, 7 or 8 different ways of treating that. If one doesn't work, you can go to the other one. That's pharma. That's advances in pharma. But also, of course, laboratory work. So let's see the results of some of these new therapies. Stomach cancer is a very aggressive cancer. It is a killer when it's in the advanced stages. But this person had HER2 positive stage 4 stomach cancer. We talk about HER2 as being a breast cancer marker. It's also present in 20% of stomach cancers. So she received chemotherapy with trastuzumab, or Herceptin, that blocks HER2. That was all based on clinical trials. So on the left upper is a CAT scan. You can sort of see a gray area in the middle, which is the tumor blocking the entrance of the esophagus into the stomach. And that doesn't look too bad, right? Now you put a PET scan in there, and all the black is radioactive glucose being taken up by the cancer and glowing. That is a PET scan. Not good. You can see all the way in the neck, too. There are lymph nodes. This is stomach cancer that were spreading to the lymph nodes. Supraclavicular lymph node, right? What's it called? You know. Okay. To the right, this is after several months of chemotherapy with trastuzumab. You don't see that tumor in the stomach anymore. This is the cross-section CAT scan. And look at that. The black blob in the middle of the right is the heart. That's not a tumor. So this is just the intestine. It's outlining her normal function. There's absolutely no cancer there anymore. And she's 4 years doing great. Well, that's targeted therapies, and we did say that it's coupled with chemotherapies oftentimes. But the biggest revolution, and now the #1 drug seller for all cancers, is a drug called Keytruda, or pembrolizumab. Its cousin is Opdivo, and you see that on TV, Yervoy and Opdivo. So this is where it comes from. The immunotherapy revolution, basically, I have to say, everybody thinks that there's some supplement, there's something they can do to boost their immune system and fight cancer. And of course, as an oncologist, and maybe you know people who turn down cancer therapies because they're going to fight it on their own with nutrition or to boost their immune, or they'll go to some naturopath, or I'm not saying there can be good ones, but some people will try to sell you something or sell you on an idea that your own immune system can fight cancer. Since Coley's toxin, I think, 1920, there's a surgeon at MSK who injected tumors with bacteria to try and elicit an immune response, and it did work. But they had a lot of trouble after that. You don't want to infect somebody. That wasn't the therapy, but it set up a premise that the immune system could attack a cancer, and it was very important. It took a long time, and research, and NIH funding for the guys that won the Nobel Prize to discover this process. But it's pretty elegant and simple. What they discovered is that on the left-hand side, you see it says suppression of T-cell activation by a tumor. Basically, if you have a cancer cell or a tumor, your immune system is kind of there, but it cannot attack the cancer. Why? Because there's a molecule called PD-1, programmed death receptor 1. When it binds PD-1 ligand, like a lock and key from the tumor cell, it's like a force field. The cancer is blocking the immune system. T cells are right there, cannot do a damn thing. And there's also something called the T cell receptor that would help kill this cancer cell if it was allowed to. Now, what they discovered is that if they blocked this PD-1 molecule over here to the right with an antibody, you disrupted that lock and key, the T cell receptor can engage the cancer, and the cancer can be attacked. This is what Keytruda is doing. This is what Opdivo is doing. And I asked one of the inventors of this, I said, what else is going on? They go, that's it. Now you understand how this works. No, I mean, it's more complicated, but this is the key to how these drugs work, and it's incredible. And so now you're an oncologist, and you have a sample, and a patient, you want to know if their tumor can respond to the immunotherapy. Well, we do a test for PD-L1, also called a CPS, or combined positive score. Regardless, it tests that cancer. Does it express that area? Does it express the immune recognition molecules for Keytruda? And this one has 90%. It can range from 0 to 90 or a little above, but that's a great score. And someone like this, depending on the cancer, you'd expect them to have a tremendous response to just immunotherapy. So this is melanoma. Metastatic melanoma was a very, very, very horrible cancer to live with very shortly. There was aggressive chemotherapy when I was training. The hell did I train? In the 90s. I hated it. So now this scientist, James Allison, discovered that a molecule called CTLA-4 and a drug called ipilimumab, or Yervoy, blocks that immune receptor. Is another, like PD-1, there are two. PD-1 and CTLA-4, they both are involved in T-cell recognition. So we've learned to give them together. If you give them together on a commercial, you are extremely happy, but this is real. So the patient has melanoma that is metastatic to the right chest, the left arm. You can see it in the skin, to the right skin. Some in the middle is the intestine, so don't let that distract you. Those are the main areas. And after these 2 drugs, you can see that chest tumor is gone, the one on the left is gone, all those are gone. Here's an even harder situation as a man who had, you see his this is a PET scan, so what's glowing is the cancer. All the gray and black and dark area there in the abdomen, the whole abdominal cavity is filled with melanoma. Okay, to the right, after ipilimumab and nivolumab. So those are just the normal kidneys functioning. The tumor is melted away. I'd recommend you to watch this movie if you haven't. You'll like it. He won the Nobel Prize for the discovery of this immunosuppression or checkpoint inhibitor therapy for cancer. So what are the other immune therapies? Well, people may have heard of CAR-T, chimeric antigen receptor T-cell therapy. What is that? Basically, these are not drugs. These are therapies that we have to help the patient to recognize their cancer. And in order to do that, we look at the normal situation on the left. There's a tumor cell and a T cell, the immune cell. There's a whole complicated system of the T cell receptor having to recognize the tumor in a specific way. HLA is particular histocompatibility. It's a tissue recognition molecule, so it's specific for each individual. But they've adapted this process on the right. They've taken the elements of the T cell receptor and they've jiggered it to a chimeric antigen receptor that now binds to that tumor antigen on the cancer cell. Doesn't need the HLA molecule, so it's much more reactive. And so this is, again, phenomenal work that was discovered at University of Pennsylvania and MSK. Carl June and Michelle Sadelain, the 2 scientists. And so chimeric antigen receptor therapy, we now give it for a lot of lymphomas, leukemias, multiple myeloma. Often it's not the first therapy because there can be toxicity, but it has salvaged and cured many people who were out of options. And how does that work? Basically, you go there, you donate your cells on a pheresis machine, they take out the immune cells, send it away to the company, and the company will inject that receptor. Somehow they'll make the cell express the receptor, grow it up, expand it, return it to the person. And then the cells are off and running in the body to attack the cancer. So they introduce a gene into the T cells of the person specific to the cancer. This has worked great for a lot of these blood cancers, not yet approved for solid tumors, except in rare occasion. The other big immune therapy breakthrough is called BiTE, bispecific T-cell engager. So this is something that we're doing at Norwalk Hospital, for example. It's not, and cellular therapy is coming too. But again, this is now an antibody, like PD-1, like Keytruda or Opdivo. It's pharmacologically made, it's a drug. You can administer it to an individual. It binds to both the cancer cell and the T cell, not to bring them together. So it's a different mechanism of bringing the immune system to the cancer cell. Now, we can't gloss over the fact that a lot of cancer therapies have side effects, and immunotherapy has side effects. These antibodies that block PD-1, well, they can attack your cancer, but they can also attack any organ in our body. So if our immune system goes overactive because of them and attacks our lungs, we can get pneumonia, pneumonitis, skin rash, diarrhea, a whole bunch of things. But we have gotten very good at checking those, knowing when they occur, and to stopping them in their tracks. CAR-T and BiTE therapies are a level ahead in terms of toxicity, greater, so they have to really be given in the hospital with caution. We can't make any advances without clinical trials. Again, All this discovery goes on in research laboratories all over the country. And then the cells that are promising go through different phases of trial. Now, it used to be that, to get a drug approved, they had to go to a phase 3 trial. Some patients got the treatment, some patients don't. A lot of that has changed. In that for many incurable cancers now, phase 1 trials, a new drug that's been rationally designed. It's supposed to bind to a particular molecule, and you recruit patients with the advanced cancer who have that change. That's a whole different story than finding a random chemotherapy and testing it on everybody. This is targeted therapy, so the results have a chance of being more promising. Of course, they have to be worked out. Just because it sounds great doesn't mean it's going to be great or safe. But just to say that even phase 1 trials are now producing results, some of which lead to direct drug approvals. But still, there's always decisions. When deciding to do a phase 1 trial after you've had all standard therapy, efficacy is, of course, important. What are the side effects and the inconvenience? Is it worth traveling for this therapy, or is it just, it's just not worth it? And you have to weigh different factors for that. I guess we're running out. I don't know how much time we have. Okay. So I just want to say one thing about difficult diseases like pancreatic cancer. So there's a drug called RMC-6236, made by a company, Revolution Medicine. They discovered, again, these are protein models. This is that RAS protein in the cell that's always driving pancreatic cancer when it's mutated, as it is in 90% of pancreatic cancer. So this was called undruggable. RAS was undruggable. So this is why so many drugs failed in pancreatic cancer until now. There's been successes. What this shows is, on the left-hand side, the percent change from baseline in the target lesions, meaning the tumors. You can see that either they grow up to 100% or they decrease by 100%. And this is over time, patients receiving this different pill, how much the tumor has shrunk. And in this case, you can see the vast majority of people with advanced pancreatic cancer who've had all standard chemotherapy, the disease control rate, meaning the cancer either stopped growing or shrank, is 87%, which is profound. That's a major advance in pancreatic cancer. It's not a cure, but it's definitely a buying time and is an improved therapy. It's not approved yet, hopefully soon. This is just a case. For example, a situation on the left, you see a pancreatic cancer spread to the liver. In the circle is the liver metastasis. After 6 weeks on treatment, the cancer metastasis has shrank. You never see that in pancreatic cancer. Now we're talking about pancreatic cancer. I'll just close by going full circle to early detection, which is a project of mine because pancreatic cancer is best cured if caught early, but it's rarely caught early. However, if it can be caught in stage 1, the cure rate is 45%. For stage 4, we've talked about it's 3%. But since most people are not diagnosed early, the cancer survival rates are like 10%. Anyway, some families with pancreatic cancer or who have a BRCA mutation should undergo an MRI. It's now approved by many guidelines, and so insurance often will pay for it now. If not, there are studies. We have a study that will do it for free. More importantly, that's only 10% of people that have pancreatic cancer in their family. 90%, it just affects anybody. It can hit anybody. It's random. And, the fact is, how do we catch that? What are the early symptoms? There's only one early symptom we know about, and that's new onset diabetes. So if you're well, you're over 50, you're 60, you're 70, your health is great, and all of a sudden you develop diabetes and you're losing weight, that is a red flag sign for screening for pancreatic cancer, we think. We are running a study to try to prove it. And the other aspect is if you have stable diabetes, it's been going along for years, you're on metformin or Januvia or something, then all of a sudden, for no reason, the control is lost and you lose weight. Again, the pancreas cancer is screwing up the pancreas and its ability to produce insulin and the body's ability to respond to insulin, because the pancreas contains the insulin-making cells and the cancer. So this is an early sign. So we have a study called Pandome, and you'll be hearing more about that. So I want to thank some of my colleagues who provided some of these awesome slides. Some are local, some are in New York. I want to thank you. I think that's it. Do we need a prostate break? A water break? A few minute break? What do you want to do?
Due to the timing, I'm going to suggest going on to the next section.
Okay.
And then we can ask a few questions at the end.
Okay. Okay. Everybody ready? Okay. So this is something that I guess because I have gray hair, I can deliver. After having been an oncologist for a while, I have had soaps. Whoops. Hold on. Whoa, look at that. Okay. Okay. Dealing with cancer is really hard, even if you're cured or the cancer's removed and things are going well. There's always doubt about things coming back. There's always worry. But it's hardest, of course, if you're living with cancer. And as I showed that graph of so many millions of people living with cancer or surviving cancer, it's a mix. People are having to be able to receive treatment and live with cancer, but still always having the sort of Damocles over them, not knowing when things are going to turn south. And so it's something we deal with all the time. So we'll talk about it. So I know Dr. Bob is an expert in this, but you can all think about the doctors you've seen and the physician's role in managing illness. There's really three classes of ways physicians try to manage illness. We diagnose it, try and determine the cause, the prevalence, the stage or extent of it. We talk about the treatments, even if it's knee surgery, right? There's different causes, there's different ways of treating it. I mean, a bum knee. And prognosis, recovery times, predicting the course of disease, if it's an infection, if it's COVID, what have you. No matter what you go to the doctor for, you really do want to know all these things. But which categories do the doctors spend the most time in? Let's just say, which one do the doctors spend the least time in? Who thinks it's prognosis? Raise your hand if you think it's prognosis. Yeah, I think so. Yeah, it's easy to just say what it is, and here's a prescription, and you'll be fine. So prognosis is complicated, especially in the field of oncology, because it is at once about the generic and the individual, the typical and the atypical, the treated and untreated course of disease. It touches on the difference between knowing and communicating knowledge, between personal and professional domains, and between subjective and objective realities. What's that? This is from a phenomenal book called Death Foretold, Prophecy and Prognosis in Medical Care by Nicholas Christakis. I tackled a very hard topic. So, prognosis. When you have cancer, you want to know the type and grade of the cancer. Obviously the type. What type is it? Is it one of those? That is determined by the location and what the biopsy shows. You want to know, is this going to kill me? Is this growing fast? Is it slow? Can we watch it? What's the stage? Is it localized or is it metastatic in terms of solid tumors? Blood cancers, like something like multiple myeloma, we don't talk about spread like that because the blood cancers, and like Dr. Altbaum said, the lymphatic cancers are often throughout the body when they're diagnosed. It has to do more with the curability or not, depending upon certain characteristics of the cancer, like prognostic models, predictive factors. Anyway, the age of the person, their level of illness. If you have cancer and you need chemotherapy and you have kidney failure and you have heart failure, it's going to be tough. And you have to, this is where the art of the art of oncology comes in, where you have to know how to manage and balance treatments and not cause too much toxicity. And then there's something called the biological essence of a cancer. Every patient is unique, and you have to respect the person and the cancer. And I wrote that in my book. So let's talk about Anita, 67-year-old therapist from your town or a neighboring town, treated for rectal cancer 4 years ago. She received chemotherapy and radiation, again, standard treatment, eradicated that. She was in surveillance, and we did CAT scans, and we found a new lung cancer with bone metastases, and she showed up to the office in extreme agony with pain. And we made the diagnosis. We'll talk about her treatment, but as soon as she knew this, she's a very savvy person. This is what she said: what are my chances? Really, don't bullshit me. Why don't I just end it? Tell me why. And what's the point of treatment? I'm going to die soon anyway. So if you're ravaged with cancer and it's causing a lot of pain, and you know it's like lung cancer, you know those are normal thoughts. So here we are, and the oncologist has to answer this question routinely about prognosis. What is hope? Is there no hope? Do we ever say no hope? What's the uncertainty surrounding it? So how did I respond at that time? I did try to comfort her. I did take a deep breath. I tried to gather my thoughts to tell her in the right way. I did pray my own way, and that I would do this right, really, and tell her that we actually have a lot to help her with, not just the treatments, but the support. That's one of the reasons I'm here, because it's a great center, great caring people that really do care about the individual. And we have some staff here tonight. But I had to read her words. Was she listening or tuning me out? Did she believe the things I said? Did she trust me? And these are things you ask of your own doctor when you're sitting there. You know, I'm not listening to this guy. I'm getting the hell out of here. It depends who you're talking to. I mean, these things, we know that, you know, it's going through your head, it's going through our heads. What's her prognosis? So this is several years ago. Stage 4 lung cancer spread through her body. 6 months, 12 months, 2 years, 4 years, it's a range. What should I tell her? The fact is, it is a range. Any cancer prognosis is generally a range. There is sort of an average survival in the middle, lung cancer, and then there's those who are surviving better. Some may have extraordinary responses. Others may not respond to treatment at all and perish soon. And so there's no way an oncologist can know that, but you have to say something. So the ability of physicians to prognosticate is equated with showing restraint, maintaining a sense of perspective, and knowing one's limits. You know, a lot of people will go to a surgeon, they'll get it out of the surgeon and say, okay, you know, you're cured. I'm like, there's too many unknowns. Acting on predictions to avoid futile treatment, but offering realistic hope based on the latest advances requires assiduous data collection, substantial learning from good sites, excellent judgment, considerable courage. This is talking about the doctor. I mean, the individual affected is the same. It also requires a commitment not to abandon the patient. And interestingly, I think not to abandon the doctor sometimes. The bond is extremely important. But you know, this gets to, there's a lot of high-level thinking in caring for somebody with a life-threatening illness and caring for them and conveying that and listening to them. And that's all critically important. So what did I do? I addressed her pain with medications. I referred her to certain specialists. Wait, let me see here. Actually, okay. I think there's a slide missing. So what happened was she had severe back pain. She had a bone metastasis. They sent her to a neurosurgeon in the area, Josh Marcus. He took it out, and that was a great relief of her pain. I sent her for radiation to stabilize that area, prevent any cancer from coming back. And then she came to me with all this information, with the diagnosis of advanced cancer, and she was still, recovering from surgery and was very raw. But we had to talk about the possibilities that we do bring a lot to the prognosis. Depends on what we're going to treat with. The genomic profiling, I showed you that foundation medicine thing. We're going to look at the tumor types. Immunologic testing, chemotherapy, we would need to resort to it. So you've heard all this before. So you'd be ready to receive it. I really wanted to convey that hope is based on advances. Although at the moment, she was in a very dark place. And when you're feeling like that, you're not really hopeful. So in terms of true advances, this is 2002, a New England Journal of Medicine article. It was the state-of-the-art survival for lung cancer. And it was 4 different pretty aggressive chemotherapy regimens. And this was the state-of-the-art in 2002. The best researchers were just studying different chemotherapy regimens. And what it shows, percent survival going down. And you could see that only 20% of people survived 20 months. So lung cancer was terrible. And didn't matter what chemotherapy you got. And fast forward to today, we talked about a mutation in EGFR receptor and a treatment with osimertinib over here at the top blue line. And the bottom, the red, is another targeted therapy, but you can see that the average survival is 3 years. That's average, so many will live more, some shorter, but this is just the pill. These are the advances we made. And of course, there's immunotherapy. If she was a smoker, so she didn't have that benefit of the targeted therapy, so we looked at the immunotherapy option based on data like this, where for stage 4 lung cancer, now you could see that blue curve is stabilizing, and it's going like this, so it's no longer dropping. This is why patients are being cured of lung cancer, because the immunotherapy trains the immune system to attack the cancer, and those cells live on. And so 32% of people are alive at 5 years from lung cancer. That was this 2 decades ago. That's advances. I mean, show this to the government. Right? So, okay, so we were able to talk to her and tell her, yes, she had aggressive cancer, but she was generally in good health. We did that PD-L1 score, prognostic models. Her PD-L1 score was 90%, so she was highly reactive to Keytruda. She did not have any driver mutation, like we said. She did have a KRAS mutation. And that was all based on just sending that tumor to one of these genomic companies. 2 weeks later, you get a result. It tells you everything about the cancer in terms of targeted therapies that we know of now. So now the new bell curve has to have immunotherapy here with long-term survivors. It's no longer a bell curve. Okay, so she did get surgery, radiation. She was just treated with Keytruda. She had consultations at our hospital with palliative care, which managed symptoms, our great psychosocial staff for support, nutrition, integrated medicine. By 6 months, she was completely recovered with no pain, is back to normal, and has returned to her therapy practice. And now it's 4 years later. And she's not even on the drug anymore. Cats, yeah, it's great. So that is the geniuses of science at work. And when things work great, this is what's happening. Of course, she asked me, how long do I have now? Can't win. This is why we're doing better. Okay, so pancreatic cancer is still one of the diseases that are difficult to treat because we have not advanced very much. There are some advances. Most of the advances you hear about coming from universities and their lab, they're all very early. Many times you'll be provoked by certain things. Oh, new cure's coming. Well, it's in a mouse. And I remember when Judah Folkman, who is the discoverer of angiogenesis therapy, drugs like Avastin, there's a whole group of drugs that block blood vessels coming into a cancer. And this was a pediatric oncologist and researcher who discovered that when no one else believed him that cancer needs a blood supply, he pioneered the work himself. He made these incredible discoveries. He started a company, and they came out with a drug, and in animals, in mice, the results were fantastic. And I remember he was interviewed on some Dow Jones. The stock went crazy. And they asked him for a comment. He said, "What do you think about this drug? Is it going to cure patients?" He goes, "It's great news if you're a mouse." He was very honest. That drug didn't work, but everything else since then has in the angiogenic field. So you can't believe all the things you read about as possibly working. Anyway, pancreatic cancer can be devastatingly fast. Some people barely get to treatment sometimes, or it can somehow be indolent. And the middle curve, you can get a treatment, respond for a while, get another treatment, respond, and keep going. Others seem to be doing great, and then the bottom falls out. And it's just hard to predict that. And so prognosis is the elephant in the room. Whether or not it's discussed at each visit, it's foremost on the minds of everybody. The problem is there can often be another treatment. For an individual with metastatic breast cancer, there are 10 lines of therapy. That means different treatment changes that can continue to control the cancer, though not cure it if it's advanced. But of course, if you're alive, if you're staying alive, you leave yourself open to the option of the next breakthrough. So multiple myeloma, lymphomas, multiple lines of treatment. And so when is yet another option best not mentioned or not even recommended, as it will do more harm than good? Blaise Pascal was this polymath in the 1600s, genius, geometry, made a lot of seminal discoveries in math and some in physics, but he was trying to come up with a rational reason to believe in God. And he said, basically, he set up this 2x2. If God exists and he believes in God, then he's going to have infinite gain because he'll have eternal bliss. If God does not exist and he believes in it, he's going to lose because he's believing in something false. On the left, if he does not believe in God and God exists, he's screwed. If God does not exist and he does not believe, it's a finite game. He can feel good about himself. But he realized that that box, eternal damnation, that trumped everything. So he decided to believe, just in case. Why do I talk about that? So there's actually, this is adapted from something called the oncologist's wager that another oncologist published previously. I like to call it more the oncologist's dilemma, but it's also the person's dilemma. If you have cancer, if the cancer is sensitive and you treat, you improve yourself. There's a benefit. If the cancer is resistant and you administer more treatments, oftentimes that's false hope. You're hoping this treatment will work, even though it's not going to. And you lose time, you lose precious time. If we don't treat and the cancer is sensitive, well, you've lost possibly a benefit. You've lost time that you could have gained. If you don't treat and the cancer was resistant, then you do benefit significantly because you can have what's called death with dignity, or doing it not in a hospital, but your way, our way. And so for doing all those, making the right wager, you need to have a good grip on prognosis. I think it's important that patients and families can be in the dark about limited time, often believing things go well. I think that it's important not to just go in, say, how you doing, get the treatment, and you're out. If it's a serious cancer, it's important to check in on the big picture from time to time. So there's often a lack of awareness to get affairs in order and spend time with loved ones if the prognosis is not conveyed. If someone is getting a second chemotherapy for pancreatic cancer not looking good, or an advanced cancer, it's obvious things are not going well and there's not a conversation about it, then everybody is harmed, mostly the person being affected because they're not making the most of what time may be left. Of course, we can't be exact, but also toxic or experimental therapies at the end of life, you need to maybe avoid those. And there can be dismay and disbelief when the time comes if you haven't been told or prepared. It may be the result of the physician not being able to cope with death and have the discussion, but sometimes it happens and no one remembers that it happens. Why physicians may be reluctant to give a prognosis. They're uncomfortable in the role of a prophet. I don't think they make profits yeah, we're moving along here? Okay. Fear of making an error. They don't want to admit that they've failed and there's a lack of time. And these discussions are extremely charged, ritualized, anxiety-provoking, they're hard to have. I just say that denial about a reality of a situation can be on both sides of the stethoscope. If a person says the cancer is incurable, a person may respond, I will be the exception. They say this is the 4th treatment with a low chance, the oncologist says, the person may say, I will take it. I'll do anything to stay alive, and that may be reasonable. Or the oncologist may say further treatment will do more harm than good, and the person will say, I'm not ready for that, I'll go somewhere else. Of course, if someone is young, has young children, if a family is in conflict, and the kids haven't been in touch with mom in a decade, and then all of a sudden they're on the scene and they want to save her from everything, that's a problem for everybody. There's a bunch of reasons, but the special oncologist-patient bond forged over years is an important one. If someone has survived with a cancer and their oncologist really has deep affection and admiration, it's hard to cross that boundary into saying that things are not working anymore. But there's always hope. Cancer treatments are improving. It's always important to be aware of the current standards and clinical trials. A poor prognosis does not mean we have nothing to offer. It's important to have a support team, and everyone in the healthcare team must understand what the patient hopes for. An upcoming wedding, graduation, family event, to live 10 years, or if they're 90, they want to make it to 100. It's important to know what a person is really focusing on. And that's it. So I want to thank my colleagues at the Whittingham Cancer Center. Thank you. To the administration for supporting research, for the patients and their families, and to my family, Miriam and my kids. Thank you.
If anyone we have time for a few questions, so if anyone has questions for either of the two doctors, please come over here to this microphone, and that way everyone can hear you.
If there are any questions, please go up if you have any. Try to keep them as questions and not too personal, if possible.
Did you say that you were operating a study right now for pancreatic cancer?
Pancreatic cancer, which one? The treatment or the early detection?
Either, whatever.
Yeah. Right.
And how would someone apply for this study?
So early detection, we have 2 studies. If there's a family history of pancreatic cancer or the individual has a mutation in the BRCA gene, we will do an MRI, even if insurance doesn't pay. But the diabetes study, if you know somebody that's over 50, they have new diabetes, worsening diabetes, losing weight, they can call us. We'll do an MRI for free. Everything's covered. Just call us. Go online. Nuvance Health pancreatic cancer screening.
Hi, I'm just curious if you think that CRISPR technology or AI is going to advance the treatment of cancer.
CRISPR technology. So CRISPR is gene editing, and it has advanced diseases where there's single gene defects, like sickle cell, thalassemia, where there's a hereditary defect. You can splice in a normal gene in the bone marrow stem cell and create healthy blood. It's a little harder in cancer because to edit every cell is difficult. That's why that hasn't really made its way into it. But it is being studied for sure. AI, I think people feel there's a lot of hope in diagnostics. Because right now you're at the mercy of the mammographer or someone reading the CAT scan to see if you have a nodule or not. There are AI programs that are going to revolutionize radiology reading, but also AI is having a profound impact on drug discovery. All these proteins that we talked about that are mutated, AI is coming out with all kinds of new chemical formulas to block them. So it's going to greatly expand treatment options, but actually treatments that need study in clinical trials. So clinical trials have to be funded. They are the worst funded part of cancer research. Clinical trials, for example, sponsored by the NIH, get the lowest funding of anything. I don't think it's going to improve. Anyway, yes?
Yeah, hi. In the first part of the presentation, some of the slides talked about a T cell. What is a T cell? I've heard about it on the news and other sources in the past, never really knew what it was.
What is a T cell?
What is a T cell? A T cell, the immune system is an interesting, the immune system basically has different types of recognition of something foreign. It's basically to protect the body. There's an innate system which basically is just white blood cells and various chemicals that fight everything that's foreign. It's very nonspecific. And then there's an adaptive system which is made of T cells and B cells. These are lymphocytes that are little cells in the body that the B lymphocytes make antibodies. Antibodies actually recognize certain chemicals called antigens and can fight them. And what's beautiful is once they recognize them, they can make many more antibodies. They multiply in response to it, and they can kill that antigen. So if it's a bacteria that has a certain antigen or a virus that has a certain chemical on it, the cell can make an antibody, and that antibody will kill it. A T cell is a cell that actually, it's the cell itself attacks the foreign substance or the foreign invader, whether it be a bacteria, a virus, or a cancer cell. And it actually is capable of releasing chemicals called cytokines that actually destroy the cell by a variety of reasons. And that's very specific. Unlike the innate system, which is just very generalized to anything, the adaptive system can be very precise. And so when you read about these CAR T, which Dr. Frank mentioned, they are creating cells, T cells, killer cells, basically, that are targeted to that very precise cancer. If it wasn't targeted, it could start killing the organ itself. You know, it could be a lung cancer. You don't want to kill the lung. You want to basically attack just the cancer. They're able to do this now through molecular I'm trying to think of the right, manipulation is probably the best word. Well, I want to thank you all again for coming, and I really appreciate you staying. It was a long lecture and a lot of information. There will be, the next medical series will be on June 3rd. We'll be addressing another serious subject, breast cancer. We'll have 2 speakers from Norwalk Hospital and Nuvance. And basically we will do that. That will also be about an hour and a half. We'll try to leave a little more time for Q&A, but tonight, obviously, we had enough time anyway. So thank you all for coming, and I really want to thank Dr. Frank.